We're talking about a little bit of mental health and some physiology, anorexia versus bulimia, nervosa. And then I decided to add refeeding syndrome so that you can understand what is going on with these patients, their condition. So we're going to talk about something they like asking in mental health. So listen to it carefully and get some few information important information that may help you in your exams. Very important topic, and you got to know it. So these are one of the eating disorder that you have to know. First, in these two conditions, you should be able to, when they give it to you, divide it into segments. So what is their psychological problem? They're trying to figure out what is exactly going on with them. They preoccupy with their body image. Okay. Afraid of gaining weight. Afraid of weight gain. These are the key features of anorexia. So they will try and do things. They can purge, or they don't eat at all, so starve themselves, or use laxatives and to lose weight. They exercise nonstop, so exercise like nonstop. Even when they are in the hospital, they want to exercise. And so those are the key features. Then you have to take into consideration what is going to happen. When they do that clinically, this will manifest itself. In terms of what they're doing to themselves. Nutritionally, they're very, very poor. They don't eat. They drain themselves and they lose weight. They starve themselves up. So clinically, so the clinical features is very obvious. Okay, the BMI is less than 18.5. That's the lowest it can be. So the BMI is really, really low, and they will have certain features that will make sense. Okay, because they know eating, their menses will be regular menses. Okay. Or they may not have menses at all, so amenorrhea, basically. So this is key feature of that. And then they will lose their hair because your body, your hair on your skin there's high mitosis. There's a lot of changes going on. So your body will lose all of them. If you nutritionally, it's a sign of nutritional deficiency. Your skin undergo multiple and changes every 3 days. So there's new generation. You break, you destroy or you shed all the dead cells and you put in the new cells on your skin to cover you. So skin is very, very good mitotic tissue that undergo multiple changes. So if you nutritionally is impaired, it shows up on your skin. That's the reason why. And then their skin will become dry skin. Then this feature that you probably know about in kids, they develop this linungo. And what it means is linungo basically is a sign of malnutrition. And these are very, very soft, fine hair on your skin and indicate malnutrition. Why did they develop that? Well, their body, because their skin is so dry, they have lost their hair. They develop this linungo. Remember, this is what the kid, when you are in your uterus and your mommy's womb, you develop this linungo. It's a sign as you grow, you shed them inside the uterus. So why would an older adult, 18-year-old, be developing linungo? Because the body want to protect itself. Okay, it just want to insulate the body, and they are very good at insulating and keeping the temperature warm, your body warm. So the linungo is designed to protect the body and then insulate the body, because the anorexia people, they've lost their regular hair and their skin is really, really dry. So they will lose a lot of heat. So they usually hypothermic. Because of that, the body will grow the primitive on your skin, and that is the lununga to insulate the body. So if you see that, that's all what it means to insulate the body. So usually these people will show up in the hospital, okay, because they have a problem, they've lost weight, they need to be taken care of. So when they come to the hospital, what do you do? Intervention wise. And for Maslow, physical needs is more important than their psychological. So take care of their physical need. And what is that? Well, you got to give them the nutrition. So nutrition, and replace their electrolytes. So those are the key words: nutrition, electrolyte before their psych needs. Okay, so that's what you do when they come in. So how is that process is going to work? What is that physical need? How is that going to work? How are you going to do it? First, you have to be, when you're providing nutrition, you need one-to-one when you're feeding them, one-to-one, especially 1 hour after you feed them, so that they don't purge, okay? So that they don't go to the bathroom and then purge all the food. So after they eat, 1 hour later, you have to do it within 1 hour. 1 hour later, you go and observe them and watch them for one-to-one, because then they will vomit everything out. Okay, replace their electrolyte. Okay, and then now you got to accept their feeling. You got to acknowledge it. You got to acknowledge their feeling. That's how then you start to provide a psychological need. Acknowledge feeling. You want to know how they're thinking, so you give them a journal so that they can write. So they can write about how they're feeling. Sometimes they're doing what they're doing because they've lost control of their own body, and maybe something's going on in the family, so they're doing this. So after you provide their physical need by feeding them, you start to acknowledge their feeling. You give them journal to write and they are feeling. Okay, by the key thing like schizophrenic, you bring them to reality. I'll put in letter reality. Make sure they will tell you they look skinny. They will tell you they look no. They'll tell you they look fat. They will tell you they're obese. You acknowledge that, but you then you bring them reality and say no. I don't think so. Your weight. You have to bring them into natural therapeutics and talk basically, and tell them, look, your weight doesn't indicate that you are overweight, and you explain it to them. So you always have to present reality to them. This is the fact. If you're not going to eat, um, you don't tell them if you're not going to eat, you're not going to leave. No, you tell them if you eat and we get certain weight at a certain time, that will ensure that your health is coming to the right place. So you let them express their feeling, but your reality is always the best thing to say to them. And so make sure you acknowledge that and keep that, because they will be hungry, they will be mad. You feed them, you said after you feed them, they will tell you, you make me fat. But you have to present the fact. No, I did not make you fat. Your BMI moved from 18.5 to 19. Okay, I did not make you fat. So you got to do that. In terms of the feeding, okay, the one-to-one feeding, there is key things you have to know. You have to monitor their calorie intake. Okay, and your plan is to gain weight gain like at least 2 to 3 pounds per week. It's not rush. So they'll be in the hospital for a couple of weeks. Sometimes then people will need an NG tube if they're not gaining weight. NG tube if not gaining weight. Okay, they will need NG tube to help with that, so that you can feed them directly nutritionally. They will try to exercise in the hospital. No, no exercise. So this is what you do in the hospital. They can't do that. They will tell you, oh, they give me 1 hour, let me do sit-ups. No, no, absolutely no exercise. And their meal has to be structured, so structured meal. So that there's certain times you can eat. No, every time you can. You cannot give them food when nobody's around. So they'll tell you they eat their own time frame. No, then they will purge. They will all the food is gone. Okay. Once again, present reality for these people and ensure that they understand what is going on. So that's the key features: psychological, the physical, the treatment intervention that you do, and the physical things that you see in these people. So what lab work do you do? Okay. In this patient, when they get to the refeeding portion, I will explain to you why they have this problem. The key lab work you have to know for your test is their potassium. They have low potassium, magnesium, calcium, and phosphorus. There's a reason why. I'll explain when we get to the refeeding syndrome portion. Um, and they also have uric acid is high. So uric acid is high. That's the only thing that is high, which is not good. When your uric acid is high, you get what? Gout. In your test, they will ask you priority or next generation test. They will ask you which one is the priority, which one you should pay more attention for these people. Potassium. Okay, potassium is very important. It's a cardiac arrhythmia. So you got it. That's the potassium. So you have to replace these people. If you have to replace somebody potassium, it's so bad that you have to replace them. They need cardiac monitoring. So, so low potassium, low magnesium, low phosphate, and high uric acid is the key features of laboratory for anorexia nervosa patients. Okay. So complication. What do you see in this? What is the complication for this problem? I already said one, okay? You have cardiac arrhythmia. Okay. Okay. Because they anorexic and eating and then they basically they sometimes they purge when you try to purge and vomit your salivary gland in your mouth, the parotid gland, they get big, so enlarged parotid gland or salivary gland. If you see that as your answer, so salivary gland um, will be enlarged. Okay. Um, and then since they are dehydrated, eating, they will be hypotensive. And I told you they developed Linuga. This is to insulate their body. That tell you they are hypothermia. So the temperature is very, very low. And the last feature is the heart rate is always low. So bradycardia. These are key complications from that. So in case they give you see a question, potassium is low, cardiac arrhythmia, enlarged parotid because of the purging, hypotensive because they are dehydrated, hypothermia because now they develop lingua, they've lost the skin is so thin, they have lost their hair, and then bradycardia because of the electrolyte problem. They can also have osteoporosis, okay, the calcium because of the low calcium. So I'm just looking at the lab work in just using osteoporosis. So it's very common in these patients. So as you can see, this is really dangerous problem. And so you have to be really strict with them. You have to feed them. They will need an NG tube. If they cannot attain certain weight, we need to take care of them. But physical need trump psychological need. But you have to know the psychological issue with that. So that is anorexia. The opposite is nervosa. Okay, this one is a little bit the I think they are more dangerous than the anorexia because they are psychological. That's what deceive people. Psychological findings. Um, they too they preoccupied with their weight. Okay, preoccupied occupied with weight. But guess what? Their weight can be normal, okay, or above. So normal or high. So their BMI can be normal. So you see them normal BMI, but they waste because they eat, then they purge. They eat and they purge. So they binge, like they will eat a whole box of pizza. An hour later, they are in the bathroom purging. Okay, so or if they don't want to purge, the purge there's different kind. I see purging like two things: either they vomit it out, or they use laxative and get rid of it. So they can be dangerous. You see them normal weight, but they are more than you don't see them skin. They may be overweight, but they're dangerous because here you can read them. Okay, you can physically look at them and say, hey, I think this person is anorexic. No, they eat, they look normal. So that's the key feature. You can distinguish it between anorexia. But like I said, in my books, they are more dangerous than anorexia. Okay. So because of that, they have key clinical features, and I think you should be able to distinguish them between that one. If I have to put my hand in my mouth every time I eat and try to induce vomiting, what do you think? What is coming out of my stomach? It's an acid. So acid. When acid comes to my out of my stomach in my mouth, what is he going to do? It's going to destroy my teeth. So they have dental crisis. Okay. So that's not good. So the enema will wear off. So if you see dental problem with these people, and that is classic for that. And the hand that they put in their mouth will also be traumatized, too much trauma. And so they have this sign called Roseau sign. In case you see it, Roseau sign. Basically, if you look at their hand, there are calluses all over in their hand, on their hand because they put it in their mouth and they're trying to vomit like nonstop. You see how you can use pathophysiology to answer most of these questions. Like I said, I'm a pathophysiology guy. I think it's the basis of any diagnosis. And you can explain why they're having these symptoms. If you inducing vomiting multiple times, there's something we call esophageal sphincter that separates your esophagus from your stomach. It allows food to go in one direction into your stomach. Where if you push in the different direction, it will make you weak, and you have reflux and hernia. So you get it reflux. You can get a GERD and then reflux. Okay. Um, and so that's why those people have that. Okay, uh, which is common. And these people they also Lunugo. Don't forget they too they're more nourished even though they are BMI because the electrolytes wise they all screwed up. The electrolytes doesn't look the same. Okay, and then with their mouth trying to vomit, the salivary gland is also going to get bigger. And one that they like is this the parotid. It's right near your jaw in front of um your ears, and then that get bigger, and then it get enlarged from excessive secretion to cause vomit. The enema will erode, like I told you, it's the same as dental crisis. So I think this list is inclusive. This is what you see physically when you examine them. Physically, these are the features you can see. Something wrong. You shouldn't have resource signs in your callus. Well, if you are about the calluses is at the back of their hand, not in their palm. So that's why, and and they also have cardiac arrhythmia. So we're dealing with very dangerous problem that um, it's a psychological problem that physically it can affect the individual really dangerously. So the same thing. How do you intervene when they are in the hospital? Well, your intervention is the same. Intervention, nothing changed. Okay. Prevention in the hospital, well, structured meal, okay? You can't eat alone. We have to watch you, structured meal. And then 1 hour observation after eating. So otherwise, they go and purge, okay? And they too, they don't exercise. But they don't do that. So I mean, they don't exercise in front of you. Most of the time, they vent. Okay, so um, just be careful. Um, of course, after you provide your physical needs, let them write psychological needs. Let them write what is going on, and once again, ensure reality. You got to do that and let them express. You have to tell them that this is what it is, and be truth with them. Therapeutic communication. This is where therapeutic communication come in place. So ensure that you do that. Those are the key features of this disease that you have to know. Okay. Um, the electrolyte is also the same. Magnesium, potassium, phosphorus, and calcium is low, and uric acid is also high. But they will give you a SATA question if you want you to distinguish between them based on that. Or if it's the next gen, how do you manage them? Or which feature is consistent with that? It's the same thing as the SATA. Nothing has changed in the new exams and the old exams, except that the questions are in different form. You have more questions rather. You have drop menu, but you have to know key features of this problem. Now let's talk about refeeding syndrome. Okay, so in refeeding syndrome, this is what happens when you start feeding somebody who is not malnourished. Okay, or you start feeding somebody um, after prolonged malnourishment. So they've not eat for a long time, and then you feed them, and then all of a sudden this can be life threatening. So life threatening. Okay, you gotta be careful. You gotta be careful. I mean, they can die from it. It's fatal, and it's sad. Somebody who have not eat for a long time, more nourished, and you try to feed them, and then when you feeding them, you kill them. So let me tell you what happened. This is what I want you guys to just understand. You can use it to answer any question. So they you starving, okay, when you starving or you are not eating for a long time, usually your body use glucose, okay, it use glucose as the main source of energy. The brain use it, okay, brain use this, your heart. So brain number one, that's the one the brain uses. But then when you start like a day you've not eating, the liver will break down glycogen to give you glucose back so that the brain can use it. Okay, this is glycogen. That's the storage of sugar. As soon as you exhaust all your glucose, your body then start looking around. Hey, who can going to be a good micromolecule to use? It goes to protein. So that's how you lose your muscle. So you break down protein. And this is muscle. You break down protein to make glucose for the brain. Brain is selfish. He wants glucose. He's acting for glucose. But you get to the point, the body said, no, I can't break all my protein. He said, no, I got to find something else. So the something else is fat. And this is what happened to diabetic ketoacidosis, the same thing. So then it goes to fat and said, oh, can you help me? So fat said, yeah, I can help you. So fat become the main source of energy. When you break fat, you produce ketones. So you see the ketoacidosis. But because of the malnourishment over here, all the intracellular electrolytes, this is intracellular and extracellular. Most of the intracellular electrolyte is depleted. And the key intracellular electrolyte is potassium, magnesium, and calcium, phosphorus. These are always inside the cell. So they are all very low. You see, they are already low. These are intracellular, so it's very low. But then what happens? When you start feeding them, as soon as you start feeding them, oh, when you're feeding them, you have glucose. You release glucose. Glucose said, hey, I need insulin. So you make insulin. Insulin come in. Insulin come in and said, when you have insulin, what does the insulin do? It causes potassium. It pushes potassium more inside the cell. So insulin decreases potassium, right? Then what did he do? Insulin causes the glucose to go into the cell too, but so that the cells can use them. When you do that, the cells begin to use this magnesium, calcium, phosphorus, and something we call thiamine for synthesis to make more food like fat, protein, because insulin is driving all this. So now we already have calcium, magnesium, phosphate, and potassium already down. Now we are consuming them to make fat and protein. So in effect, you have really, really low potassium, really, really low calcium, really, really low magnesium, and really, really low phosphorus. And that is refeeding syndrome. Look at this important um, micronutrient. It's all decreased. And for refeeding, what kills them mostly is this. It's no more potassium. Low phosphorus will lead to respiratory failure. So that's anorexia. It's really, really bad. Or if this continue for a long time, the phosphorus goes down. I mean, this is what is going to happen. So you have respiratory failure. If you see a question about somebody who's been starving, and all of a sudden you start feeding them, and they start getting sick, they're getting refeeding syndrome. And it's due to low potassium, low calcium, low magnesium, and low phosphorus. And they go into respiratory failure. So you got to be careful when you're doing these patients. You have to be careful for that. Of course, the low potassium will lead to cardiac arrhythmia. But remember, this is airway. That's why this is important. This is airway problem. This is circulatory problem. So A before C. So this is why phosphorus is the most important electrolyte in case they give you potassium, magnesium, phosphate, and magnesium. Is the most important electrolyte in the patient with refeeding syndrome because it causes respiratory failure. Okay, so, and then there's another key feature, glucose goes up because of the feeding and the shift of electrolytes. Glucose go up and they become fluid overloaded. I'm giving you a SATA question right away so that you can manage it. So fluid overload, high glucose. So this is fluid overload, high glucose, low potassium, low calcium, low magnesium, low phosphorus, and you go into respiratory failure. This is the cycle of refeeding syndrome. Cardiac arrhythmia is number 2, and the refeeding is number 1. Okay, respiratory failure, sorry, is number 1. So this is what happened in this patient's condition. Very bad, life-threatening problem. You need to do something about it as soon as possible. So the question will be, how do you prevent it? Treatment. So prevention, intervention, you the nurse. Somebody, anorexia person coming, that's why we want to let them gain 2 to 3 pounds per week, slowly, okay? So feeding, one is what? Slow feeding. What does that mean? If they need 18,000 calorie, we give them what? Half of them. So we give them what? 9,000, 9K calorie for a couple of days. And then we slowly increase it. We already know that the electrolytes already screwed up. So we need to check their labs first. Check labs first before you even start to feed them. You need to check that before you start. And then you got to watch for refeeding. So these people need to be on a monitor, okay? And monitor them for BMP and cardiac monitoring. You have to do that. Don't forget about the timing deficiency. This happens because of glucose. You need timing to metabolize glucose. And so as soon as you start feeding them, they don't have glucose. Now they have glucose, they consume all their timing and they develop Wernicke. Okay. Wernicke encephalopathy. Um, and that's something that later I'll talk about. But Wernicke, they get confused, they have ataxia, in confusion, and they can go into coma. So it's so sad. Patient is malnourished. You feeding them and you overshoot, and then you put them in the very, very, very dangerous condition, and you don't want that. So slowly feed them and prevent this problem. Um, the other way, I remember one thing. The best way to remember the electrolyte for refeedium, I call it the ppm plus calcium, ppmc. Okay, phosphorus, potassium, magnesium, and calcium is all low. Then timing. So ppmc timing. So ppmc, phosphorus, potassium, magnesium, and calcium, and timing deficiency is very low. But have a high suspicion, okay, high suspicion when you're trying to feed a patient that is being not more nourished for a long time. This is all very good stuff, and I hope you learned something out of it.